If you suffer from dizziness and wonder if you are doing the right vestibular exercises, this video is for you. For those that don't know me, my name is Amy McMillan. I'm a vestibular physical therapist. I have over 15 years of experience treating patients with dizziness and concussion, and I have a mission of giving people the best current evidence-based information so that you can be empowered to treat dizziness at home and know that you are getting the best information from a certified vestibular therapist no matter where you live. So in today's video, we are going to discuss the 4 pillars of vestibular rehab. If you have any questions, make sure you drop them in the comments and I'll be sure to answer questions as they come along. If you haven't yet, make sure you subscribe and hit the notification bell so you can be notified of weekly content that I will be putting out. So the first and probably the most common, if you're familiar and suffering with dizziness, is canalith repositioning, or CRP. Now, what that stands for, the medical term, is basically a maneuver that is going to help treat BPPV, benign paroxysmal positional vertigo, or possibly you have heard mentioned your ear crystals or rocks in your ears. And yeah, that sounds funny, but there are these little crystals in your ear called otoconia that if they do become misplaced or in the wrong part of the ear, you will feel like a short duration spinning when you lay into bed, look up, roll in bed. And I also am going to put in the description below a link to our new ebook for self-testing of BPPV at home. So go ahead and make sure you grab that new ebook in the comments, in the description below. Canalith repositioning maneuvers are the most effective way to treat BPPV quick. So that is the first pillar of vestibular rehab and probably one of the most common that I perform on a daily basis. Now, the second pillar is adaptation. Adaptation is the vestibulo-ocular reflex, called your VOR. So when your VOR is stimulated, which it happens naturally, so when I move my head to the right, my eyes go left, and vice versa. So when I move my head up, my eyes go down at the same time and same speed, so I can keep my eyes on a target. Now, if that does not occur, what a patient will experience is kind of like a drunk, staggered walk. You may see that what you're looking at when you walk looks a little blurry or kind of smudges a little bit. So if my eyes can't keep track when I'm walking, and my eyes just kind of pop off really quick when I'm walking, I'll veer that way. Now, what adaptation and gaze stability exercise is for, that basically is strengthening the inner ear nerve to have your eyes move at the same exact time that your head moves in the same exact speed and relationship, so your eyes stay stable on a target. That is the foundation of vestibular nerve strengthening. Now, when we're talking adaptation exercises, this is where I see a lot of people not making gains in the vestibular rehab because it is so crucial following the evidence to do certain speed, certain time, certain exercises. Again, I have a great video on gaze stability exercises that we'll put in the description below. So I want to talk a little bit more in depth. Who are adaptation exercises for? When I prescribe those exercises, they are for someone with a stable lesion. Now that means the inner ear nerve has had damage to it, maybe from a virus, possibly an acoustic neuroma or surgery, and there is no further changes occurring with that nerve. The damage is done, so these exercises are quite effective with a stable lesion if you're doing them right. So let's go over some of the parameters for adaptation. First, you'll probably see in some of my videos a little stick like this. I'll move it a little closer. It has a B on it. If you use a target that's huge, it is not functional in what you're doing in a daily routine. Oftentimes you may be looking at small objects like your watch while you're walking. It's not a big X on the wall, for example. Or you may be looking at a light switch as you walk towards it. Now, some objects obviously are bigger, like a TV, but needless to say, I always start off with a small font. 12 to 14 point font actually is clinically significant. So when I say VOR exercises, it normally is going to involve a stable target initially, a stable target that I will keep my eyes focused on. And as far as prescription, the most important thing to remember is that when you move your head, you need to keep your object just on the edge of blurring, if not clear. So it should not look like this. It should not be super blurry. These exercises are meant to make you just a tad dizzy, and then it quickly goes away. So when you're talking about speed, I see a lot of videos promoting something that looks like this. Really slow, and you're keeping your eyes on the target, which is great, but the vestibular system is activated when you do quick things. For example, when you are looking at a car, how quick do you turn your head? It's definitely not this slow. So the vestibular system is activated when you move quicker. So when you're looking at the research, it says between 1 to 2 hertz. Now, what does that mean? What does that sound like? When I am prescribing exercises, I use a metronome. So I'm going to play the highest speed that I use, which is 240 beats per minute or 2 cycles per second. So I want you to hear this. Now, I'm doing my exercises and I'm moving. It's quite small, by the way. It's little movements, about 30 degrees. And this is the pace that I'm trying to accomplish. You won't get there day one, but eventually what I see patients when they have success, it is when we achieve quicker speeds. So if you are an athlete, if you're playing tennis or on a treadmill or a fast walker, your head moves when you walk at a much faster speed than this. So that's one error that I see with vestibular adaptation exercises. Our patients aren't pushing or being advised to go a little quicker. And if you don't go quicker, then you're not really using that vestibular system and you're not really going to see those results that you want to reduce your dizziness. So with that being said, I also want to talk about duration. With adaptation, the duration that you complete your exercises in a day. If you do 1 minute this way, 1 minute that way once a day, it won't work. The duration that the evidence suggests is 15 to 20 minutes of gaze stability exercises. So again, when you watch the video of the gaze stability exercises that I commonly prescribe, that combination, 15 to 20 minutes a day. It does not have to be completed all at once. It could be short bursts. I know that you're dizzy. I know that you're suffering. It's very hard to do those exercises 1 minute, let alone 20 minutes a row. It's not going to happen. So it is fine if you get to your exercises and you do 10 seconds and then you come back to it in another 30 minutes and try another 20 seconds. So your main goal should be 15 to 20 minutes a day. It does not have to be continuous. It can be short bursts. So a recap with adaptation exercises. 1, it's the foundation of vestibular rehab. 2, the duration matters. So 15 to 20 minutes a day. 3, speed matters. So make sure that you're trying to accomplish a speed closer to that metronome sound that you heard. So I would say 120 to 240 at max beats per minute is what you're going to shoot for. And remember, that change occurs when you get the retinal slip, meaning you get just a little blur when you're trying to keep your eyes stable, but it's not so much that you're not moving so fast that it smears all over the place. It's just a little blurry just on the edge, and that is appropriate. These exercises are appropriate for someone with a loss, a stable lesion. So we're talking maybe someone that's been diagnosed with vestibular neuritis, someone who has had an acoustic neuroma, surgery, and that tumor is no longer growing. Meniere's disease that is no longer active. These exercises can be quite stable. So those diagnoses, a stable lesion is appropriate for adaptation. The next pillar that we're going to talk about is habituation. Habituation basically is trying to tamp down the intensity that the brain responds to different tasks. I use these very commonly for patients with 3PD, vestibular migraines, or anxiety-related dizziness. So let me give you just a couple examples of habituation exercises. So let's say someone is dizzy when they lay down at night, only when they close their eyes, and they do not have BPPV. We've already checked for that. So what I will do is try to have the patient lie down, ground themselves, close their eyes, and try to get used to that sensation of falling, and then know that their body is in control. And we work from 5 seconds to 5 minutes. That's one example of habituation. Another may be going through a busy grocery store. So very common, if you have dizziness, you may notice that you're motion sick in very visually busy places. So how do we habituate to that? What we may do is watch a video, a GoPro video, of walking through a grocery store. So I can have the patient sitting in their office, bring up a grocery store on the computer, and we get used to that visual stimuli anywhere from 30 seconds to 5 minutes with just producing a touch of symptoms until their brain no longer is bothered by that visual stimulation. One last example, bending over. I already know the patient doesn't have BPPV, but yet they still have dizziness when they bend over. So we are going to do grounding in our feet, bend over, back up, bend over, back up. I traditionally recommend 5 times in a row. And what we'll do is do that exercise until the brain is not bothered by it anymore and dizziness no longer occurs. So those are just a few examples of habituation exercises. Everyone's very specific, but that is how it works. The last pillar is substitution. What this is good for is when a patient, when their inner ear, their VOR, does not function, or it is missing, it is not reliable, we are going to have the brain and the eyes pick up for when the ear fails us. So substitution exercises are things like working on your balance. So our slow march, our heel to toe, our standing in the corner with feet together. So our ankles are going to substitute for the loss of inner ear function. Our ankles will keep us grounded. So that's one method of substitution. The other that we have, you'll see a lot of these videos out there, are eye tracking or saccades, when you're back, forth, up, down, moving the eyes from target to target. So when the inner ear fails us, the brain and eyes can pick up for where that fails. So when people say I'm doing vestibular rehab and they're showing me like eye tracking exercises, that's actually a substitution exercise. Now, there's very good places for that exercise, but is it going to strengthen the ear nerve? Is it actually a vestibular stimulating exercises? No, it's not. So you want to make sure that you're using these pillars of vestibular therapy appropriately, and with the proper diagnoses. Who should use substitution exercises? Someone with bilateral loss of their inner ear function or absent function. So if you've had a VNG and there's no vestibular function, these tracking exercises can substitute for that loss of inner ear function. Patients who have had a stroke. So if you've had a stroke, it makes it much more difficult for the inner ear and brain to give you the right information for that reflex to occur because you've had damage. So if the brain, the relay center, can't be counted on, you may not get the most benefit from your vestibular adaptation exercises. So we'll do substitution. So the other clientele that I happen to use substitution are those with unstable lesions. So active Meniere's, a wait and see acoustic neuroma, somebody with changes still occurring, maybe Lyme's disease, lupus, or an autoimmune disorder of the inner ear. Those are still evolving and changing conditions. So if the vestibular system is constantly being damaged and then rehabbed, substitution exercises may be appropriate for those clients as well. I hope you found some of this information helpful. It's very medical, so if you have any questions, please put them in the comments below. I'd love to discuss and get your feedback. Make sure you subscribe and hit the notification bell for next week's video. Thank you. Let me know what you think.